Thank you so much for having me. As Letitia said, my name is Daniela. I am a first-year PhD student going into my second year of my PhD at U of T. Today, I'm going to be speaking to you about my master's research, which is titled for this presentation, Connecting Risk Factors, Physical Activity, and Mental Health in Children with Cerebral Palsy. So here's just a little bit about me before we get started. As Letitia said, I did my undergrad at U of T. I'm going to be discussing my master's research today that I did at Western, and I'm currently exploring some participation promoting strategies and interventions at U of T. Here's a picture of me on the left side of the screen with my sister and my mom. This is when we went to Alberta last summer. This is somewhere off the highway between Banff and Jasper. I wish Toronto looked like this. It really doesn't. So hopefully I can get out to the mountains soon. So let's dive right in. So cerebral palsy, or CP, is the most prevalent and most impactful long-term neuromotor disorder in children, and it affects 2 in every 1,000 infants. CP is usually characterized by a loss of motor control due to disruptions in the brain during early childhood development. And CP is known for being non-progressive, so it doesn't get any worse, but also doesn't get any better. But there are some risk factors that can affect how and where children participate, where they experience most of their days, and ultimately their mental health. And so we'll be able to see through this presentation how some of these risk factors can really be impactful in the long term for children with CP, and that can also continue later on in life as well. So before we really begin, this is what I'll be discussing today. I have a bit of an introduction as well as the objectives for this research, followed by some of the methods that we use, our results, and how we've interpreted them, and then looking forward past our conclusion and some of the implications of this work as well. So like I mentioned, although CP is a non-progressive disorder, many times children with CP experience other impairments along with their loss of motor control. So we know things like epilepsy, cognitive impairments, learning disabilities are quite common if you have CP, but there are these other factors that may be modifiable that can impact mental health as well. And so some of the things that we've determined, even from the literature, are things like pain, fatigue, and sleep disturbances are very prevalent among children with CP, that is in the beginning of life and also later in life as well. And so based on kind of these literature-informed outcomes, we've decided to focus on these 3 areas, as well as physical activity. Now, we know that physical activity for being a positive additive to anybody's everyday life, but mostly also in terms of mental health. So we decided to kind of look at these kind of 4 pillars of risk factors and physical activity and see if that can have an effect on mental health outcomes. So if they were able to predict mental health in children in our sample. So here's just a little bit of context for you. We know that 57% of children with CP experience some sort of mental health symptoms, and those can include symptoms of anxiety or depression. They can also include symptoms of behavioral disruptions, so that can be internalizing behaviors or externalizing behaviors. We also know that there's these strong bidirectional relationships between things like pain and sleep, pain and fatigue, pain and mental health, and these can all reduce or rather inhibit quality of life outcomes in this population. And so this was part of the beginning of this research, was looking at, okay, we know that there's this complex relationship going on. Are we able to use that to predict mental health outcomes? And finally, in terms of physical activity, like I said, physical activity can be very beneficial, we know, for mental health, but we do know that a decreased physical activity and an increased sedentary behavior can make children vulnerable to developing depressive symptoms. So like I mentioned, there's this kind of complex network. And so the objective of this study was really to kind of unravel that. So the purpose of this study is twofold. Firstly, it's to observe these physiological risk factors, so fatigue, pain, and sleep disturbances, as well as physical activity. So really see what's going on in terms of everyday impairments in terms of these factors. And secondly, we wanted to examine the associations between symptoms of fatigue, pain, sleep disturbances, and physical activity to determine their impact on mental health outcomes. So this is that kind of this relationship that I've previously mentioned. So we were looking really for associations between these factors and mental health. So what do we do and how do we do it? So this study was completed during the beginning of COVID, so completely remotely, and we were able to recruit participants from Alberta and Ontario Health Services, thanks to the help of the Enhance Lab and the Cheer Lab for recruitment. So we recruited children ages 8 to 18 and a family member to participate in the study. We were able to use the REDCap survey platform for electronic consent, and we were able to use the REDCap platform for pretty much the entire study, or this entire analysis, which was very helpful. So we were able to look at parent and child reports of mental health, those being behavior, anxiety, and depression. We also used an actigraph, which were mailed to participants. And an actigraph is similar to a Fitbit or to an Apple Watch. So if you've ever tried to hit your 10,000 steps a day, or maybe you're tracking your sleep like I can and you're never getting enough sleep, that's exactly what an actigraph does. And so to collect this movement data, children were given 2 actigraphs to wear for 1 week. And we were also able to collect our physiological risk factor data, those being fatigue, pain, and sleep measures. So here's a quick overview of what we found. We had our 42 participants in our final sample, and approximately 60% of those were male. We had a mean age of about 11 years old, so kind of this pre-adolescent age. Most of our participants were white, and we had 2 levels of functional ability. So you can see here, kind of in the middle of the screen, that most of our participants were independent on all surfaces. So what that means is they're able to move around independently. And also they were able to be independent on all level surfaces. And that checks out with our GMFCS level, or our gross motor functioning scale, where we were able to see that most participants were in levels 1 and 2, which means they are ambulatory. So now we're going to talk about some of our physiological risk factors and some of those results as well. So we use the fatigue impact severity self-assessment to look at fatigue. And although the FISA does not have clinical cut points, we were able to determine that children were experiencing a mild to moderate amounts of fatigue throughout the day, and higher scores meaning they were experiencing more fatigue. And this is pretty on par with levels in terms of the FISA in other populations or other studies as well. But we did have some variability, and you can kind of see that here within some of our standard deviations. In terms of our pain, we looked at 3 specific measures or outcomes of pain. Firstly, being impact. You can see here on the left side of the screen that we had participants experiencing either a little or between a little and a lot of pain, and that made up most of our sample. You can see here, though, however, that there are participants that are experiencing either a lot of pain or or very much pain, which is quite concerning when you think about an entire day's worth of experiencing kind of this chronic pain. And if you think about how that might impact your own mental health as well. In terms of severity, on a scale or a range from 1 to 10, participants fell within the number 4 range, so quite moderate, low to moderate pain. And in terms of that duration, most of it lasted for less than an hour of the day. But we can see here as well that there are participants that are experiencing pain either half of the day or a few hours up to an entire day of chronic pain. In terms of sleep, we also looked at 3 measures of sleep as well. We looked at wake before sleep onset. And so the WASO is how long a subject has been awake after initially falling asleep. And here that was around 35 minutes. You can see that in terms of their efficiency, children were sleeping about 90%, their sleep was about 90% efficient. And additionally, we looked at the number of awakenings per night, and that was about 14 times per night. Children were waking up or experienced wakefulness. In terms of physical activity, and this being, at least for me, it was the most interesting or the most eye-opening, we saw that children were doing about 5,000 steps per day. But what's really interesting here is if we look at the percent of time they spent sedentary and the percent of time they spent doing moderate to vigorous physical activity. You can see here, kind of in this left column, that children were experiencing about 80% of their day was made up of sedentary behavior. And that being either quiet time, reading time, playing video games, maybe watching TV. And so if you think about the amount of hours of the day that you're awake, that you spend doing things, 80% of that day is with quite a small standard deviation is spent seated, which is quite concerning. And then conversely, but also intuitively, we can see that their percent of their time spent in moderate to vigorous physical activity was less than 2% of their day. And we know from Canadian physical activity guidelines, which are the same for CP as they are for typically developing children, that children should be receiving about 60 minutes of moderate to vigorous physical activity per day. So we're quite off the mark with that. And you can see here at the bottom that the number of children in our sample, being 42, that were meeting these Canadian physical activity guidelines, only 2 participants, or less than 5%, were actually meeting the Canadian standard for physical activity. Here's just a brief picture of what the actigraph data actually looks like. Sorry that the picture is a little bit distorted, but you can see here that this first kind of graph here, which is looking at waste or physical activity data, that these areas of red are periods where children are not exercising or not conducting a lot of movement. You can see that because it's the waist, that would mean a turning of the trunk. So it is, you do need to perform more physical activity for the actigraph to pick up on that, but the waist and wrist data is noticed in the literature for being the most accurate in terms of collecting movement data. And you can see here from the wrist data that even during periods of sleep, that there are movements between sleep and waking up. So whether that's between 9 p.m. at night to 9 a.m. in the morning, there is a lot of wakefulness that is happening, especially for this participant at least. So in terms of our mental health measures, we examined 3, those being internalizing and externalizing behaviors as measured by the BASC-3. We also looked at anxiety symptoms using the MASC-2 and depression symptoms using the CDI. And so what did these look like? Well, for internalizing and externalizing behaviors, and internalizing behaviors are more, and Carly can speak better to this, but are more, so those internalizing symptoms are mostly of anxiety and depression kind of related, whereas externalizing behaviors being lashing out or very expressive behavior. We can see here that we both had, so we had child and parent reports for this measure for all of our mental health measures. And we can see here that the mean, or the score at which these children were able to report on, was roughly approximately 50, which is in this average range for the clinical cut point. We can see here that parents are either overestimating or they have a higher mean for internalizing and externalizing behaviors, and we'll be able to see that as we go through the rest of the mental health measures. We can see a similar trend here as well. Our child reports are reporting at a mean about 52, which is right here on the graph. And as you can see, the graphs are different as we go along because, or the images are different as we go along because there are different clinical cut points. But we can see here that there is a discrepancy between child and parent reports where parents are overestimating or maybe they're just reporting higher levels of anxiety that they witness in their children compared to what their child is actually reporting on. So you can see that there's quite a big discrepancy here as well. Something else to note is that we do have these large standard deviations. And what that means is that there can be children that are experiencing up to almost 14 points higher or almost 12 points higher than the mean, which means that there are children that can be within the elevated or very elevated ranges. And that was pretty consistent among all mental health measures that we looked at. And the reason, maybe a reason to maybe alleviate this is also with a higher sample size as well. In terms of our depression scores, we can see that, again, there is a small discrepancy, but again, large standard deviations with mental health symptoms. We can see that the child reports fall within the 53 range and parents fall within the 58. You can see here that they are falling within an average range of depressive symptoms, but we do have some children that can be falling within the elevated or very elevated ranges, and those would be of concern for a clinician. So we have all of these variables, and so what do we do with them? So After kind of examining all of these and examining the literature, we decided to take 5 variables to explain or to predict mental health outcomes in our sample. And so we conducted a backward stepwise linear regression and selected these 5 variables to predict these mental health outcomes. So we looked at our total fatigue score as by the FISA, our pain severity, the WASO score from sleep, and then 2 measures of physical activity being the percent time spent in sedentary and the percent time spent in MVPA, or moderate to vigorous physical activity. And these were determined by, like I said, the literature, and also if there was variability within the variable. So if we were able to see variability across scores, it was more likely that we would choose it to include it in the linear regression. So here's what our analyses look like. Although there are a bunch of numbers on the screen, I want you to keep your attention to kind of the right side here. The only significant models of significance that we found were within the child report of the Children's Depression Inventory, so the depressive symptoms. And as statisticians will tell you, the p-value is not everything. So there may be, so it may be that these physiological risk factors are predicting some of the variance for anxiety symptoms or internalizing and externalizing behaviors. But for the purpose or for this analysis, only the CDI for the child was able to come back significant. And so as I turn your attention just here to the right side, we're able to see that pain, sleep, physical activity, as well as fatigue were all contributed to the variance of the significant models. And as we go along and variables are dropped off, we still see that model is significant. And so what this means, this value here, the suggested R squared, is that for about 30%, if you think about mental health, or in this case, the child-reported depression as being 100%, and 30% of that 100% is made up of these determining factors, which is quite significant. So we do see that these factors are able to predict mental health outcomes only for the child report here. And so that also raises questions about if the parent and child reports, if there is this discrepancy, which one is the most accurate as well. And so what does this mean? So all the physiological risk factors, so each of these 5 that are checked off here, and physical activity, we're able to predict child-reported depression scores in our sample. And like I said, the p-value isn't everything, so there may be other biological mechanisms that are predicting mental health outcomes that are associated with these physiological risk factors. But based on our analysis, these are the significant values that came back, or statistically significant values. And so quickly here, we are able to see that each of these factors are able to predict mental health outcomes. And so this is important when we think about things like interventions. Perhaps there are ways to look at mental health as kind of from a holistic standpoint. Are we able to target these modifiable risk factors? And I used that term earlier because if we are able to, for example, alleviate pain or alleviate some fatigue in this population, will that have positive impacts on their mental health? And based on the results from this study, it might. So if there are other ways that we're able to kind of target mental health rather than solely from a psychological perspective, that opens up a lot of doors for families that that don't have access to psychological intervention or other interventions, but if they're able to kind of alleviate mental health in other ways, it can be very beneficial for the population as a whole. And so what did we find? Just to sum it all up and tie it up with a bow, physiological risk factors, so pain, fatigue, and sleep, and physical activity were able to predict symptoms of depression in children with CP from our child reports. Additionally, children with CP experienced lower levels of physical activity compared to physical activity guidelines. That's that less than 5% that I mentioned earlier. Additionally, they experience a range of mental health symptoms, including internalizing and externalizing behaviors, depressive and anxiety symptoms. So some limitations of this study: this is a cross-sectional study, so it's an observation study, which means that it is not causational. So we can't determine that there is a direct relationship between between the risk factors and mental health, but we do see that there's an association. So longitudinal data is needed to kind of confirm a direct relationship. Additionally, we did have some issues with recruitment and sample size. This also being during COVID, parents are apprehensive about participating in studies, obviously when there's a lot of greater and important things going on. We also, and because of this, these are kind of go hand in hand, we did have some missing outcome data as well. And like I mentioned, that there can be a bidirectional relationship between these physiological risk factors and mental health. And the way to kind of alleviate that, or I guess confirm that, is through longitudinal studies that can determine a unilateral relationship between mental health and pain, fatigue, and sleep. So why does any of this matter? Well, for researchers, clinicians, and families, it's very important. Like I mentioned, if we're able to kind of determine other avenues of interventions, and especially how we treat and how we go about looking at mental health, this research is extremely impactful. And looking forward, like I mentioned, we need longitudinal data to determine these causal relationships and perhaps curating mental health interventions to target other avenues. So like we saw with our physical activity demographics, physical activity is quite low in this population. So are we able to use that as a means for an intervention later on? And so these discussions can start to happen when research like this is able to be conducted and kind of widen our perspective on what mental health actually means. And so I just wanted to leave you again with this kind of graphic. So we did determine that physiological risk factors are able to predict depression symptoms from our child reports in this analysis. And I decided to keep this kind of like last question mark up here, because as science changes, we do know, and it changes very rapidly, that there are other avenues, and mental health being so complex as it is, there's obviously other things going on underneath, but determining some of these factors can progress, especially mental health research, which has become so prevalent in the last couple of years. And so it's important to look at these different avenues for interventional change. So thank you for listening to my presentation. I left my contact information up here if you want to talk further about this. I wanted to thank Dr. Laura Brunton, my supervisor, for this work, as well as Dr. Carly McMorris. I saw that Elizabeth is on here as well, who is also a part of this study. Thank you, and the Cheer Lab and the Enhance Lab and the Robertson Fund as well for allowing this research to continue. Thank you so much, and I will stop sharing my screen.
Thank you, Daniela. Thank you for the wonderful presentation and for taking the time to share your work with us. I'm going to just quickly introduce the other three panel speakers, and then Daniela will join in to help answer some of the questions. So today we have Jake joining us. In September, Jake will begin a degree in astrophysics at the University of Calgary. He has mixed ataxic and spastic cerebral palsy. He has played sledge hockey for many years and enjoys hiking in his free time. We also have Dr. Laura Brunton, who is an assistant professor in the School of Physical Therapy at Western University and is a registered physiotherapist. Laura's work focuses on understanding fatigue and pain and the relationships with physical activity, sleep, pain, and mental health. And finally, we have Dr. Carly McMorris joining us, who is an associate professor in the Workland School of Education at the University of Calgary and a child clinical psychologist. Carly's research focuses on improving mental health and well-being for children and adolescents with neurodevelopmental disabilities. So first question I'm going to pose to you is, given the links that you're seeing between the physiological factors and child-reported depression, which factors, either based on this work or your personal experiences, which factors would you recommend as a starting point to target to improve mental health?
Carly, I saw you on mute. Do you want to take that first and then I'll jump in after?
Sure. I mean, I think each factor is really important. So I don't want to diminish, and I don't know, as Daniela sort of mentioned, we looked at this cross-sectionally, and I think our goal is to really understand this more longitudinally. But when we look at the cross-sectional data, in my opinion, the pain piece seems to be most influential, as well as sleep. And so I think we want to sort of take this holistic viewpoint, but if I had to put sort of my money on where to sort of intervene first, I think we have some really solid interventions for things like insomnia and sleep problems that could be really adapted and modified for people with CP, as well as pain. I think is something that's we know is there and impacts mental health quite substantially, we're finding so far. And so those would be my suggestions, but I think Laura's going to say the opposite. So that's why we're on a team together.
It's so funny because I think, like, you know, having been in this world for a few years now, I think we think pain is low-hanging fruit, that we can adapt and we can change some of the pain management for this population, but we've struggled so much about how to accurately manage pain in this population. So I think it would be my target for sure, but I'm leery because everything we've tried to do has not really caused a lot of change for pain. And then you look at something like sleep, and I think sleep goes really nice and hand in hand with fatigue. And I think that's probably where we can make a huge bang for our buck with really low investment and with like very basic education kind of based strategies and interventions. So I guess it depends on where you want to put, you want to put the work into the developing something that we have struggled with for years, or do we want to put some work into something that we might get some really good outcomes out with quickly, which I think is needed in this population when we look at the mental health crisis that they're facing.
For me, just based on my experience, I definitely agree that sleep is definitely important because it decreases fatigue, as we all know. And it can help with pain too, because your body just replenishes during sleep. Yeah, so I just find if we can if we can find a way to increase the amount of sleep, not the amount of sleep, but the quality of sleep that people with CP are getting, I think that can benefit. Yeah.
Yeah, and I think you bring up a really good point there, Jacob, that, and we've looked at it, and when we were trying to pick our outcomes for Daniela's study, we collected a lot of different things, and you had to kind of decide what outcomes we're going to put into the regression. And so we weren't sure whether it was quality or amount of sleep. And I think the short answer is it's not one or the other. It's probably both that have to change, right? And so the thing that stuck out for me, and again, hearing Daniela present this again today, like the number of awakenings per night is something that, 13 awakenings per night, that to me is like, that's clinically significant, even if it wasn't impacting their mental health, right? And so it just makes me think that there's so much that can be done with a relatively, non-complex intervention around sleep hygiene and sleep awakening. So there's lots of possibility there, I think, is the big thing that I want to kind of highlight, and that you can look at quantity and quality separately or together, and probably have to do both.
I think too, what I just highlight is that we have a really good sense in neurodevelopmental disabilities in general, or neurodiverse individuals, that sleep significantly impacts things like suicidality, depressive symptoms, and isolation. And it's bidirectional for sure, but a lot of variability, as sort of others have alluded to, is a significant driver in that sort of relationship between feeling depressed the next day or socially isolated, or how we respond to stressful situations. And so I think you're right in that sleep is a huge factor. And any way that we look at it, how refreshed people feel in the morning can drive a whole bunch of things, both physiologically and their physical health, but also their mental health, for sure.
I see Elizabeth has a question or comment related to this question. So go ahead, Elizabeth.
Yeah, I just want to sort of stretch at the next step and maybe challenge Laura a little bit on intervening on sleep not necessarily being easy, because we do talk about it in clinic. Although I do, you know, these are all related. And so in our robotic gait training research, we have found that, well, I think through increasing physical activity, we are considerably decreasing sleep disturbances. So do we take it the next step back and work on physical activity to decrease sleep, to decrease pain, to improve mood?
Yeah, and I think that one of the limitations that why we didn't see physical activity as being somewhat significant in this model is just the low physical activity rates that we had in this population. And so I think that's really important. I want to clarify, I don't mean that fixing sleep is easy, but I think there are a lot more interventions that are evidence-based in other populations that I think we can very easily adapt to this population as something to start from. Whereas when we go to the pain world, I mean, there's so much in pain that has been done that has shown no benefit. And it's a lot more complex when we think about the sources of pain and the types of pain and the chronicity of it. So it makes me think that there's hope more for sleep. Whether it's easy or not is a totally different question, but I think there's a lot more accessible to us from a clinician standpoint to be able to do something. And I think physical activity is a great one, and it would probably be where I would like to start as a physical therapist as well. So I know from my clinical experience that whenever we get kids more active, the sleep comes a lot more naturally. So that's also helpful as well. The other thing to mention in this population is just the amount of different sleep kind of modes or things that are happening at sleep. So there's still co-sleeping, there is still, medications and things that interrupt sleep. So there are a lot of complexities to that are kind of individualized in nature that also require an individualized approach, which makes it so hard and so interesting at the same time.
Laura, I just realized when you said that we hadn't looked at some of those other factors involving sleep as well. So if there were medications present or anything else. So that also can disrupt it. But again, each case is so complex that you can't, that you need something that is adaptable. I feel like sleep, I think, Carly, you mentioned about pain being like low hanging fruit, or no, Laura, you mentioned a bit about it being low hanging fruit. And I do think that is the case, but I think in terms of feasibility, sleep just seems like the way to go. It does seem like it's pretty central, especially in the literature.
Excellent, thank you. So the next question, given that lower levels of physical activity amongst youth with disabilities is a finding of yours as well as other studies that we've seen, do you see this as an indicator that we need to look at physical activity guidelines differently for those with disabilities?
Being the physiotherapist, I'm going to jump in, but Jacob, go for it. Actually, take it ahead.
No, you go first. You go first.
I was going to say, I don't know that we need to change the ultimate goal, because I think there's very good literature out there that shows that if we can get to this level, that we can change physiological factors that are important for health. So I don't want to change the top level, but I think what we need is something in between to scale kids and families up to reach that level, because it's very daunting when you say that to someone that they need to be active for 60 minutes a day. That's a long time in some of these kids' days. And when you look at 1.5% of their day being in that target, it seems unreachable. So I think there's something that needs to happen in between that to get them there, and to get them there in a way that's really kind of, somewhat stretched out and thoughtful in order to make that a habit that they can sustain and maintain.
So from my perspective, I don't think we should really change anything. No, like, I don't think we should adapt. Because like, sorry, just because everybody needs that exercise, and but I understand that people, like, there's different severities of cerebral palsy, and like people have like different pain levels and stuff like that. But I think it's important to at least try to get 60 minutes of exercise every day, just because like this research says, that it can impact the mental health of the participants. And yeah, that's just my perspective, at least.
Something I think about when you talk about like bridging the gap, I guess, is something that I've recently started looking into, things like meaningful, like solution focused coaching and what's meaningful to the family and what's feasible to the family. I think that is something that bridges that gap a lot faster, because yeah, you can say 60 minutes of PA per day has to be this type, whatever, and that's not always accessible for families. And maybe a lot of kids don't want to be doing that. So there's other ways that you can still be achieving that kind of physical activity where your heart rate is up or whatever it is, but it has to be meaningful and appropriate for each family member. So that ties in like this whole other component of coaching, and that will end up being sustainable long term when you build these kind of foundations with families. So that's where my mind went immediately when you said that.
Yeah, and I think it's hard because our life has changed, in the way that we do things, not only from the pandemic and people's access to being physically active has changed in that way, but over time it's changed as well too. And just when you look at play histories of children, and with or without disabilities, right? Play has become a lot more difficult to be unstructured, that reaches that level of physical activity that we know creates health benefits. And so, changing that number isn't always going to help us, because I think it doesn't really change the health benefits too much. But if we can try and, just emphasize the fact that, we don't expect that if you're going to become physically active, that tomorrow you're going to hit 60 minutes and you're going to do 60 minutes every day for the next, 10 years or 15 years of your life, that it is this variable thing that, fluctuates over time, and, more is better, but some is good too. And I think that some is good too message gets lost a lot of the time. And so I'm really excited to hear and to see things in Participation, for example, where we talk about, building up physical activity for 10 minutes at a time, multiple times a day, and really making that accessible, I think is really, really helpful. And so ways that we can really think about that and work that into children's days, I think is probably also more helpful. So if we look at the education curriculum, for example, there are lots of teachers that are missing the boat of the fact that, if you can be physically active for 10 minutes in the classroom, that you actually might get a lot more cognitive power out of that as well. So linking that within the day, and not just thinking that physical education is, something you do for 30 minutes one day a week or 3 days a week, depending on what your school board prescribes. So there's lots of opportunity there for that as well too. And I think we just have to take a different approach to how we get kids active with or without disabilities.
Excellent. And those are some really great suggestions in terms of, getting people more engaged in physical activity now, and getting them more physical activity, but especially coming out of the pandemic where people haven't had those opportunities and need to build back up to that. I guess a question a little bit more related to those who already have started to get engaged in activities. Do you have any suggestions for coaches and programmers that they could include within their program for mental health interventions?
You can go ahead, Laura, first, and then I'll add.
Go ahead.
So what I mean, from a mental health perspective, we know that any kind of physical activity is helpful, right? But we also know that involvement, I'm sorry if that's the question, Letitia, I got kind of, can you repeat it maybe?
Yeah, for sure. Do you have any suggestions for things that coaches and programmers could include within their program to, for mental health interventions?
Yeah, I mean, I think in another hat that I wear, I'm quite heavily involved in Special Olympics and do a lot in terms of mental health benefits for Special Olympic athletes. And so one of the things that we talk a lot about with our athletes is any kind of sport that you're involved in requires a strong mind as well as a strong body. And so we talk about how these things have to kind of happen at the same time. And we talk to coaches about how a lot of times our athletes might be stressed, and that's totally normal, that's totally acceptable, et cetera. But there's some certain strategies like deep breathing or progressive relaxation that can be really helpful right before a game, for example. We also know that like social support and supporting of others and kind messages can be really helpful, and helpful thoughts that we can adapt depending on someone's ability to communicate both verbally as well as written, et cetera. So I think the message is that anything is good, and that any kind of strategy, big or small, can be really helpful. We also know that there's a lot of athletes or individuals with neurodevelopmental conditions or disabilities more broadly who experience sort of clinically relevant mental health. And so what we, one of my postdocs, Dr. Bree Redquist, she is doing some great work on coaches understanding the new normal, or people who understanding, I shouldn't say the new normal, but people's own normal. So coaches giving, having a resource where they can identify when they're not, what their normal looks like in terms of their mental health. And so coaches can recognize when they're not normal. So I'm usually really quiet, but when I'm stressed, I like to talk a lot. And so with those kinds of resources, we can have coaches that can be really identifying when a kiddo or an individual is sort of stressed or feeling higher levels of need in terms of their mental health. I don't know if that answered the question. Laura, do you want to add anything?
Yeah, I think it's all about like meeting people where they're at. And that's, you know, if I was to have a tagline for kind of how my thinking has evolved around physical activity and mental health for these, you know, this population and for kids in general, it's really just meeting people where they're at and finding out that what's that individualized connection that you can make. And I think that's the beauty of, you know, rescaling after the pandemic, is that sometimes, you know, you have the ability to make those connections with families that you haven't chatted with in a long time, or that are coming back to a program or new to a program. It kind of makes you to think back about like, well, what am I getting back to? How am I getting people active again? Why am I doing this? Why are they being active? And really making that connection again, as opposed to just kind of running a program over and over and over again. And really thinking about how you're going to reconnect to those families, because I think you need to meet them where they're at, both in terms of their mental health support and for physical activity.
Okay, 2 more questions for the panel. So based on this project and your experiences, are there potential unintentional negative consequences that programmers need to be aware of when designing adaptive physical activity programs?
I think the easiest answer, probably one of the easiest answers, is the one size fits all method. I think that even creating a program, as difficult as that is, obviously there has to be some sort of structure. So I think it can be quite difficult when you're trying to adapt to so many varying abilities. And like we saw here, if you have children who are experiencing pain or they're not, or they're experiencing more fatigue, so they can't participate as long, I think it's having the understanding that there will be more modifications than you already think. So you can always plan for more, but there are going to be other things that have to be amended later. I think that's probably one of the things. I think that's probably the easiest answer. Yeah.
I think that like the physical literacy piece is something that often gets missed, and particularly with kids who have disabilities, and CP being one of them, is that we kind of overlook the physical literacy component of physical activity programming, and just really thinking about like getting people to know their bodies. So just reading the comments in the chat between Elizabeth and Carly around like guided relaxation and, you know, progressive relaxation or stress release, like really getting to know their body and feel what that body feels like is really important, and particularly important when you have things like spasticity or fatigue or you know, pain happening in multiple regions, is that there's that mind-body connection, and some of that physical literacy piece I think can really help us bridge that gap, and could be a really fun way to explore that in physical activity programming. So so it makes me think back to my like undergraduate kinesiology roots, which I know are well appreciated here in this group. So really thinking about, you know, deliberate preparation of how we're going to get people to know their bodies, to then be active in their bodies, and then to link their bodies and their minds.
Yeah, one of the things that we find super helpful is, for example, that linking piece between mind and body is always really powerful for individuals. And so, for example, we have a lot of kids who talk about having stomach aches for a really long time. And then after a little bit of intervention and talking about their mind and body and how they're connected, a lot of times they recognize that they're actually butterflies and they're nervous or worried. And just by doing that raises awareness around anxiety. And then when they should use these kinds of techniques that might not necessarily be easily implemented if they don't know when to do that. So definitely, I think those early literacy kind of pieces are important for sure.
They will. Sorry about that. I definitely agree with Daniela about the adaptations for everybody, just because everybody has some, like, there's so much very variability, especially with CP, just because there's just so much variability with us. And I definitely agree with Carly too, with the with the relaxations, because that can really help just calm the body down and stuff like that.
Yeah, somewhat unrelated. We there's another student in my lab who's doing a project around like defining and exploring the differences between pain and fatigue, because they're so intimately linked. And I think Daniela alluded to that in her background. And some of the strategies that are coming out of that, I think, are strategies that could be very easily, woven into physical activity programming, and teaching people from a very young time how to recognize what tension in their body looks like, feels like, what it is, how to rid themselves of it, and how to make an impact on the rest of their day. And so there's a lot of work happening around, self-management now. And I think the earlier we can get that into people's lives and to manage, hopefully we'll predict or be able to kind of stop and halt that cycle of deconditioning that leads to kind of low physical activity, that leads to more pain, that leads to fatigue, and all of those things, particularly in this population with kids with CP.
Thank you. All right, I received a question from one of our audience members, so perhaps she can correct me if I'm getting this wrong, but do you know if the development of mental health illness can have an increased incident as a result of the trauma itself? So the upper motor neuron lesion versus developing from an individual working through fatigue, pain, lack of sleep factors?
I'll take that one, I guess. No, the short answer is no. I think the literature is still pretty minimalistic in terms of disentangling those two pieces. I do think that there is a huge need for more longitudinal work to understand sort of how mental health develops and why in kids with CP, and then also why there's some individuals who that maintains well into adulthood. And so I don't think that we've been able to sort of identify that, but I do think that there's bits and pieces around or that are meaningful, both sort of physiological and, like you said, that sort of trauma piece, but also these other factors. And we haven't even really talked about sort of social environment either, which I think is a huge piece as well. So peer relationships and those sides of things, as well as just social context that I think are impactful. So I think that's not really an answer, but that's where I think the literature is at right now. But it's a great next direction for sure.
Yeah, and I think to touch further on that social environment piece, like the caregiver relationship is another huge thing that we haven't really even started to unpack at all in the literature. And so, children live in families, and families have their own dynamics, and parents have their own, positive and negative mental health components as well. And so the same thing goes for physical activity, right? So physical activity often happens within a family environment. And so you have parents that are pro physical activity and parents that are less pro physical activity. And so all of these factors are really hard to disentangle. But what we do know is that these are additional risk factors that if someone already has underlying mental health concerns, that these are probably things we definitely need to intervene on and change. And even if we can't change the underlying piece of the brain, there are some modifiable factors, as Daniela has mentioned, that hopefully we can target with intervention at some point in the hopefully near future.
All right, so we've got a little bit of time left, so we'll open it up to a general Q&A. You're welcome to direct questions to any of the panel members or to Daniela regarding her work.
I have a question for Carly. So while people are waiting, I'm just going to think, when Daniela was presenting the difference between the parent and the child reports, I'm just curious what your thoughts are, and if you want to chat to this group about the difference in parent to child report, and where do you put if you had to put your eggs in one basket, which one would you put it in?
Great question. And this is something we struggle with all the time. So just as a side note, we do clinical interviewing with parents for these, all the kids who have participated in the study. We have sort of interviewed parents as well to get a sort of more rich understanding of their mental health. Findings are to be sort of presented at a later date. But what we find in any sort of neurotypical or neurodiverse or people with disabilities is that there's a certain time and place where parent or caregiver report can be really valuable, but there's also a time and place where having someone self-report on their own mental health is super helpful. So the two things that we sort of typically think about are age. So kids who are reporting about their own mental health, typically between 11 and 12 is when we sort of decide that they're the most reliable reporter of their own mental health, versus caregivers are typically the ones to kind of talk about or notify or be the most responsible reporter for kids under that age. We also know that depending on what symptoms they're reporting on, a caregiver report can be more valuable than a self-report. In particular, when it comes to sort of anxiety and depression symptoms, those are internalizing or internal thoughts. And it's really hard for parents to sort of make determinations about whether their kids are experiencing that, versus someone who's experiencing it can kind of speak better to that. Versus, and if anybody has had kids, they know that sort of you can really see externalizing behaviors, whether it be aggression, attention difficulties, and often people underreport their own attention difficulties or aggressive behaviors, like, no, mom, I didn't go and hit that other kid, versus those who sort of parents are sort of more better at reliably kind of talking about those sort of externalizing behaviors. So again, it's sort of putting together the picture of who you're asking and at what age and what you're asking about. But we often see that parents overrate mental health symptoms regardless of what it is. Yeah. And interestingly enough, after intervention, we see that gap in reporting actually gets smaller. So after about a 14-week intervention, what we typically see is that there's this large gap between kiddos and parents reporting of anxiety, for example. And by the 14 weeks, we see this super small gap. So parents and kiddos are more similar.
And is that because one increases and one decreases, or do they teach that? Like, how? that's
yeah.
Really
Kids actually meet their parents. And typically that's just with that sort of physical literacy piece that we were just talking about. So noticing that, gosh, I haven't actually just been experiencing a stomach ache, it's been my mental health this whole time. And so you're bringing awareness to what you're actually experiencing. And that seems to be really helpful. Yeah, the recognition side. I think so too, Daniela. Thank you.
If there's no further questions, then we'll wrap up today. David?
I don't have any questions. I just have a comment. I really enjoyed Daniela's presentation, but I also really like the panel format after that. So I am very supportive of this new model we have. So, and I thought you did a great job moderating too. So that was it. Just a comment.
I echo David's comments. Thanks for a great talk, Danielle, and for everybody that participated in the panel. I think that I expect we'll have lots of positive feedback on this format. So thanks for that, everyone.
All right. Again, echo those comments. Thank you, Daniela, for the wonderful presentation, for taking time to share your work with us, and to each of our panel members for the stimulating discussion following that. So give everyone a couple of minutes back in their days, and have a great rest of your Thursday, rest of your week.
Thanks, everyone.
Thanks, everyone. Take care.
Thank you.